What we're going to do is I'm just going to take us through a few slides just to orient us to our conversation today. And then I'm going to stop sharing a screen so that Dr. Salerno and Jan Winhall can have a conversation. As a reminder, this is part one of a two-part interactive experience with Jan Winhall, who is a distinguished scholar in the field of social work and psychotherapy. And she's sharing all of her information about working with individuals facing addiction in response to trauma through the lens of the Felt Sense Polyvagal Model. And we do invite you to join us for part two, which will be on April 20th from 10 a.m. to 12. In today's conversations with Dr. Tony, we'll speak with Jan Winhall about her many years of experience treating addiction with the Felt Sense Polyvagal Model, which is a way of understanding addictions as state regulation strategies and the autonomic nervous system. This conversation is also designed to invite you all to ask questions as well as to share what you're doing or what you have done in your work treating individuals who've experienced addiction. So without further ado, I will pass it on to both Dr. Tony Salerno and Jan. And thank you so much again, Jan, for being with us today.
Thank you, Kara.
Thank you, Kara. And thank you, Jan, for sharing your insights with us on an issue that is an extremely challenging one for all of us. And I'd like to just start out a little bit more on a more of a personal side. And, you could have done a lot of things with your career. You could have focused on all different problems, right?
Yeah.
How come you, what led you to really focus on this area of addiction as an important area to really spend your career focusing on?
Well, I used to start answering that question with when I just graduated from graduate school, but I'm going to go back because I realized upon reflection that really I think underlying it was the fact that I had grown up in a family where people were struggling with addiction and certainly with really profound mental health issues. So I think that was the underlying piece. And then what happened is I went into social work and I graduated and I started this job fresh out of school, being told that I was running a group for women who were incest survivors. And that really shaped my whole career. And the book that I just wrote in June, Treating Trauma and Addiction with the Felt Sense Polyvagal Model, is really, the model is the development of the work that I started doing there 41 years ago. And basically these young women taught me what I then took and went on a journey to try to figure out and help them to understand what they were doing in terms of really intense self-harming behaviors. And a lot of those self-harming behaviors became addictive because they were so effective. But they were things like, I mean, we heard about cutting the body and whatever, but there were also things they were doing like chewing bars of soap, things that I didn't understand at all, and neither did they. Except on some level, they knew that it helped them. So that's really where it started. And I got so intrigued by it because I've got a curious mind that won't let go until I figure it out. And yeah, that was the beginning.
So Jan, what you're referencing is that when we think of addiction, I think people most commonly think about drug and alcohol, but you're expanding that definition of addiction.
Yes.
To include all sorts of things. Can you say a little bit more about that?
Yes. And so what I saw back then was a lot of these behaviors that were like cutting or eating huge quantities of food, binging and then purging, so vomiting, things that brought what Judith Herman described in this, her wonderful book, The Gift That Keeps on Giving, of trauma and recovery, that brings jolts. They jolt the body. And so as I listened, what these women, we basically were figuring out was that these jolts in the body helped them to numb. So they were shifting from what we called in those days as feminist therapists. We didn't buy the traditional pathologizing agenda. We listened freshly to what was going on for these young women. And we called it flooding and numbing. And that's what it is, right? Sympathetic flooding and then the dorsal numbing. And so then, yeah, I always understood behavioral addictions as addictions, because through the polyvagal lens, we understand addictions as what I call propellers, or what Steve Porges calls state regulation strategies, because he's a neuroscientist and I'm a therapist, so I call them propellers. Yeah.
When you see all of these, let's say, excessive behaviors or these ritualized behaviors
Yeah.
or obsessive behaviors, there's like, it sounds like they serve a function, that
Yes,
there's
they
actually
do.
a purpose behind that. Well, that's an
Absolutely.
interesting kind of thing. So,
Yeah.
okay, so it isn't like people just wanting to get high or being irresponsible or whatever it might be, that they're trying to actually do something to kind of get themselves well.
To get themselves to be able to survive.
To survive.
To survive, yes. And so when the body goes into these traumatic states, these feedback loops of sympathetic and dorsal back and forth, addictions are these really efficient ways of shifting, right? So for example, if you're feeling really that flight fight feeling in your body, you drink a lot, or you cut the body, for example, the body then shifts into a numbing dorsal state, that because it releases these endogenous opioids that help us to bring relief when we're not able to calm the body down from a ventral grounded place inside. So what would we do without that? What would we do if we didn't have these ways of adapting to maladaptive environments?
Mm-hmm.
It's not people that are maladaptive. It's the environment that these women were living in that was highly, remarkably maladaptive, right? And their bodies found these ways to adapt to bring relief when they couldn't find it through safe ways. And so when you tell people this, it is remarkable. That's the heart of the paradigm shift in working with addictions.
So when you tell people this, if people begin to shift their understanding of their own behavior,
yes,
that has huge impact on how they see themselves, and also as part of treatment, that's an important part of treatment. Can you say a little bit about that? Because it sounds like there's a strong educational component to the work that you do.
There is a strong educational component. So it is a psychoeducational model. It is polyvagal theory is a top-down, bottom-up approach, right? It's very bottom-up because we work in the body and we notice these neurophysiological shifts that occur in the body. But it's also top-down because we teach people how to work with those shifts in the body to bring in a grounded ventral place. So when we understand addictions through the body, we understand that bodies are simply doing what they were designed to do to survive. And so while we're not in any way minimizing the destructiveness of addictions or how it hurts, our family members, not in any way are we doing that, minimizing it. Mm-hmm. But what we are doing is saying to folks that are struggling with addiction, your body is just doing what it was designed to do to survive when there was no other option because you didn't have enough safety. Mm-hmm. And this brings what I call moments of liberation. People talk about healing from shame and guilt. It's remarkable. And you can see it in their bodies. They shift into a more ventral state. I'm not a bad person. No. Some things that you've done, people do bad things. But you in and of yourself, your body just responded the way bodies instinctually are designed to respond. And I think we've just missed that because most of our treatment and our training is so top down. And so when you're so oriented towards cognition, you miss the beauty of how bodies actually work.
Well, it's interesting, Jan, when I first read some of your work, I was reminded of some of the work of Arnold Lazarus, who's a psychologist, who talked about something called the multimodal approach. And in that, it's called basic id. So there's behavior, basic stuff, behavior, affect, which is what you're saying. But there was two pieces in there. Remind me of what you're saying.
Yeah.
Sensations,
Yes.
bodily sensations, and also imagery,
Yes.
visualizations and things like that,
Yes.
which I must say, and when I reflect on the work that I see that's kind of prevailing work in therapy these days,
Yeah.
I don't think there's much emphasis so much on sensation or on imagery or on looking at sort of like those bodily sort of functions, or on how do we connect the behavior to a person regulating their nervous system. I don't think that
Yes.
that's a very common approach to treatment today.
Well, I think it's starting to come into the field of trauma, but it's been so CBT dominated but it is starting to come into the field of trauma in terms of just paying attention to, for example, mindfulness practices, yoga practices, things like that. So you see there's some, but polyvagal theory, the thing that excited me so much about it is that it really helps us to understand what Steve calls this intervening variable. So at first I thought, what is that? What's he talking about?
Right. What's intervening?
But I got it. When I got it, it was like, oh yes, of course we get this. It's the way in which when our body shifts states, it changes the story. So as Deb Dana will say, that story follows state, such a simple way of saying something. So for example, if you're in a sympathetic state of flight fight that the majority of the world is in now, or we've shut down into dorsal. That's where we are right now because we're in a state of trauma and our little children are, and we all are in our bodies. It's just how we're designed, right? To survive. We're defending ourselves because the world is in a terrible state and we're bombarded with it every day. So the challenge for people, especially with families, is extraordinary right now. And of course, addictions are on the rise because we're all dysregulated. Right? But when we can understand, if we can slow down a bit and connect in with breath and with what we call the felt sense in the body, this is Jean Gendlin's work that I brought into and integrated into polyvagal theory. When we can do that, we start to see that in that state, for example, of sympathetic rush of fear or anger or both, and you can see how people respond, right? That our thoughts about what is happening are different. If I'm afraid, how I think about what's happening is different than if I'm feeling pretty safe. That story follows state.
Right.
So and that's how triggers happen. That's what a trigger is, right? We distort the reality of the situation because it's based on our previous experience.
Right. So in many ways, it's this idea of when we're dysregulated, the jolt, this idea of how do I get, and it's like a survival, right? We're kind of built that way, that we just can't be in this constant state of fight and flight or freeze, is that something's going to happen. And engaging in all sorts of behavior can be a way of trying to jolt that nervous system into some sort of like regulation. Would that be accurate to say?
Yes, absolutely. And it's often unconscious. So you might, kick the cat or slam the door, and if you notice, if you're really angry and you slam the door, what does that feel like in your body? There's a release, right? You feel looser somehow. It doesn't bring you back into a grounded ventral place necessarily, but it shifts you into some kind of a release of that buildup of constriction that happens in the sympathetic nervous system. Yeah.
Well, what it strikes me is when I was just thinking that, do I ever really think about my body? I really don't. Can I be honest with you, Jan? I really don't.
Really?
And I don't really think about my sensations or, how I'm feeling. That's not something that's very intentional or very conscious. Just kind of go through life, right?
Yeah.
And I'm just, when you're working with individuals, it sounds like that's one of the goals is for
Yes.
people to become more attuned to what's happening
Yes.
in their
Yeah.
bodies.
Yeah, and you know, if you're lucky and you grow up in an environment that's safe enough, you know, which some people do, many people in the world don't, right? In marginalized communities, we are always in these dysregulated states. But if we have enough safety, then we often don't even have to really think about it that much because we're kind of cruising along in ventral. Things are pretty good.
Sure.
You know, you shared with me before we started, you got a pretty good life, right?
Yeah, it's pretty good, you know.
Yeah. But if you have really struggled in your life to manage your mood, then you probably are going to head in towards addictions, because addictions help you manage trauma by either, you know, getting into that sympathetic surging place, or then numbing, or if you're in a numb place, cutting the body or jolting the body will also wake it up, because that dorsal place can feel, without enough ventral energy, it can feel like you're dying.
Yeah.
Yeah.
Well, I'm sure.
So
I'm
they
sure
can go either way, right?
Yeah.
So what happened for me, Tony, was that when I started off that 41 years ago, I realized that I just was, I don't know why, but I never bought the traditional model. I was a kid of the 60s. I was reading Thomas Saz, The Myth of Mental Illness. And
yeah, I'm there with you.
Yeah.
I'm there
and
with you, Jan.
I was a feminist, and I saw the way these women were treated in this hospital setting, and it was terrible. It was terrible. It broke my heart. So I went hunting, and I knew something was going on in the body. And so I found Eugene Gendlin's work, brilliant man who was originally a philosopher, trained with Carl Rogers. And then he did this amazing work that they did together in really noticing what happens, what produces change in the body, and noticing this process that occurs where if we pay attention, and I'll bet you that you do know this because you strike me as somebody that actually does have some connection here. So even right now, notice what's happening in your chest or down in your stomach as we're engaging like this. You can feel in there, right?
Yeah, when you know what it is, when you draw my attention to it,
Yeah.
I'm much more aware of it. You know, that's what I'm really experiencing.
Yeah.
It's kind of like if things are somewhat regulated, you kind of go through life like you say, okay. And there are times you get upset, and times you're stressed out, times you're angry, times you're frustrated, anxious, whatever it might be. But often I have to say is that the next question I don't ask myself is, okay, hold on a second. I know I'm feeling anxious about something. I got this project to get done next week. I know I'm being anxious. And the next step, though, which I think is, in your perspective, very important is, all right, Tony, so where are you feeling that?
Yeah.
You know, what's it like? Where does it sit in your body?
Yeah.
Do I have it right?
Yeah, you do. Absolutely. And what Gendlin discovered, which is so polyvagal, this is why I put the Felt Sense model together with polyvagal theory, was that if you have a partner who's listening to you, who's co-regulating, he didn't use that language, Steve would, but this is what he meant. We call it this relational felt sense. So if you have a partner who's listening to you, then, and listening with skill, deep listening. So this is what parents need to do with themselves, with their partners, and with their children. To listen to when the children are like, you've got this squiggly, tight, funny thing going on, or a tummy ache and they don't want to go to school, or you see your kids like zoning out and you can't find them. Where are they? You know, to be with our children and to teach our children. What's going on for you? You know, what do you feel right now in your body? To ask them directly. And then as you do that, and I keep you company in that place that feels really uncomfortable or kind of flat and numb, something starts to shift, because this is how bodies are designed. We are designed to connect with each other. We're designed to help each other. But look at what's happening. Yeah. Because we're so disconnected. It's very, very frightening. So now more than ever, really, and certainly in my lifetime and yours too, I think, I mean, it's like we have to really start paying more attention to how do we keep ourselves safe in our own bodies? how do we keep people safe in the world? And you see this very clearly now with COVID and vaccines. You know, all us white people, not all of us white people, but white privileged people, middle class people, upper class people, we've got vaccines. But what about the rest of the world? What are we doing? Because we're not connecting into the body and recognizing that sense of connection with each other and with the natural world.
Right. Well, you're really emphasizing the role of empathy and empathic regard for others, and that expands beyond just our own relationships, but a kind of an empathy towards a greater humanity, which is what you're emphasizing. You know, what it brings to mind for me, Jan, is that in every therapeutic encounter, there's a relationship there, right?
Yeah.
And what you're, in a way, is kind of very intentional. That, you know, I may have my techniques or my strategies, but it's not my techniques or strategies that actually provides that healing, safe environment. It's me.
Yeah.
You know, it's me. Could you
Yeah.
say a little bit more about that? Because in many ways, all of us and everyone who's on who's listening to this,
Yeah.
We're forming a relationship, but we can form one, or we can engage others in a way that creates that safety zone and that
Yes.
comfort zone, or we can do things that may appear to be, you know, perfectly fine. You know, it seems like I have a rationale, but may actually accomplish the opposite. I wonder if you could say something, you know, about that role of your relationship. Because that's the business we're all in, who's on the line right now, is part of how we help individuals to regulate and to find that comfort zone and safety zone for them.
Yeah, absolutely. So, you know, this is what we're speaking to now in part two, is the social engagement system, the other really powerful part of Steve Porges' theory, right? That when we're in a grounded, ventral, calm place in the body, we are able to make contact, to be present. Like, I can look at you, we can look at our clients, and we can really show up for them. And we can work on creating conditions of safety. So making sure that we're looking at our clients with a sense of connection and a smile sometimes, to not to be intrusive, but making sure that our faces are signaling safety, to remove any sense of evaluation. So this is part of what I think is so valuable in terms of moving away from pathologizing. We don't use, in my way of working in the model, we don't use the DSM. We don't diagnose people, we describe. And I actually created an embodied assessment tool to be able to do this through the lens of the nervous system, is how we would describe. And it's not about evaluating, because bodies just do what they're going to do to survive, including addiction. But we describe where they are. And so that's part of it. The other part is in the environment that you're in. You know, if my client comes after school and they're hungry, I give them a banana. Bodies are real. They show up and they get hungry. You make a cup of tea. You have nice lighting in your office. You try to, as much as it's possible in an urban setting, not have loud noises outside going on. Things that help people, you know, a warm blanket. Lots of times when we work with trauma, bodies get cold, you know, so a warm blanket, a cushion, a safe and comfortable, as much as possible, environment that you create. And then inside, a willingness to be vulnerable, to show up, to be a real human being with another real human being.
You know, Jan, it reminds me of, you know, the kind of mindset that we when we enter into a relationship with one of our clients is what I'm hearing is the mindset is something like this. You're doing the best you can in light of what you've experienced in your life, the resources available to you, the supports you may or may not have had in the environment, your own biological makeup. You know, it's sort of this attitude of acceptance and non-judgmentalness.
Yeah.
And that's sort of a critical factor that enables that person to experience that experiencing the therapist as they're not judging me. Then they're not deciding like whether I'm good or bad. They're not telling me what I'm right or wrong, but it's this deep interest in understanding my experience,
Yes.
understanding my perspective and how I see the world from my lens, rather than a judging lens from some
Yes.
other person. Would that be accurate to say?
Yeah, absolutely. It's very Rogerian in that sense. And Gendlin too would talk about the primacy of human presence. He wrote this paper. Oh my God, it's so beautiful. I weep every time I read it. And this, of course, goes perfectly with Steve Porges' work around co-regulation, that we show up and we allow ourselves to feel. And in doing this kind of work with addiction and trauma, you're going to feel sad, you're going to feel outraged. But if you stop feeling, you're not going to be able to show up. If you feel too much and you get flooded into sympathetic, then you're not going to be able to co-regulate with your clients. So this work is highly demanding of us. You know, we are our own instruments. This is it. You know, we can have all these wonderful theories and techniques, and they're great. I wish we had more. I mean, I love concepts. But we have to be able to put those beside us when we show up with a client and just be like this. And then some of those things are going to be helpful, and we'll want to go in and find them and use them or suggest them. But they don't dominate, and they don't get in between you and me in a session. They're beside us.
Yeah. And, you know, in some ways, the way I would kind of think about it is, with people who've gone through trauma, what you don't want to threaten is their sense of safety, but also a sense of control. That I don't want to feel trapped, right? So I'm critical in making decisions of what kind of intervention would be fine with me. So explaining, like, I have this technique or this educational approach, or here's a curriculum that we're using.
Mm-hmm.
But the notion of gaining permission, of, you know, having that person say, yeah, I'm comfortable with this.
Yeah.
I think sometimes that gets a little bit, you know, that may be one of the do's and don'ts, like one of the mistakes that we may make with greatest intention. The biggest mistakes are made with the greatest intention half the time, right? Is that we may bypass that process of ensuring that I don't threaten that person's sense of control, because I'm an authority figure, right? The person could feel a little bit intimidated, or doesn't want to turn me off, and may go along with something that I've activated their sympathetic nervous system when my goal was to not do that. Does
Absolutely.
that make sense?
Or the dorsal, or they shut down. And what you're raising is a really important piece around the polyvagal model and addiction, because what we want to do, and this is very different than the traditional models, the 12-step model, or the pathologizing, seeing addiction as a disease, which I don't see it as. I see it as a extremely bad habit that comes from learning. So what we want to do is to really harness the autonomic nervous system to work as a collaborator with us in the process of letting go of addiction. So that means that we go slowly and gently, and we check in with the body, with the felt sense in the body, to see how is the person doing in terms of their capacity to let go of the behavior that has helped them to survive.
Mm-hmm.
And so our job is to help them to become more and more present with us through creating enough safety and dignity in the room to be able to do that. And then we check. It's kind of like taking the temperature in the body.
Mm-hmm.
You know, how did you do this week? It's not, how did you do this week? And it's not, how did you do this week? It's how did you do this week with your body and the drinking or the whatever it is? It could be masturbating. It's sex addiction is a huge issue now in our culture. One that I really, really encourage people to begin to really take on as part of the treatment. I think if we're working with trauma, we're probably working with addictions, and that those two fields have been too split, and we need to bring them together. So I'm saying, let's bring them together, and let's do it in a way that addiction work is not a slog. It's a way of working with the body as a collaborator in the healing process and respecting how much the body needs to shut down in those old ways, and inviting the person. And then they'll be more honest with you. But, you know, if you end up in a power struggle over, you said you were gonna, and you, even if we don't say it blatantly, there is this implication, you should be doing this better. You know, it's hard not to feel that. But if you really go into understanding it through the nervous system and say a survival mode, it changes it. Do you see? Do you get that? It changes the whole feeling of it, of the work. And then it's like, it's not so bad. You know, people ask me like, how can you work with addiction? It's so, I'm like, it's not so bad. You're actually working with it anyway. If you don't ask the question, the person's probably engaging in addictive behaviors, but you're not addressing it. So then the body's busy shutting you down, even though the mind is saying, I know that this would be a good thing for me to connect with Tony, but I'm going to go have a drink after therapy because it was so stressful.
Right. Well, no, it's so important what you're saying, Jim, because I'm sort of like thinking, if I was struggling with addiction, I'm meeting with you. One of the things is like the idea that my work is to try to get somebody to stop doing that they rely on for survival.
Exactly.
You know, it's kind of like you got to be kidding me. Is that really?
No wonder people do it.
Yeah, and why it's hard to keep people in treatment, and why the risks of termination is so high, is this idea that the goal is to get you to stop drinking or to stop drugging, right? That's one approach. But what I'm getting from you is that that's not really the approach. At least that's what's coming across to me.
Yes, that isn't the goal. The goal, well, first of all, I use a harm reduction model. So the goal is what is the goal for you? What is your goal? Right. If we see addictions in a very simple way, you know, it helps you in the short term, it hurts you in the long term, and you can't stop doing it. Okay, so let's explore that a bit more. And we have a very concrete way of being able to do that with people. And we just get a sense of like, what do you want? What's going to help you to be able to feel safer in your body? And that really becomes the focus, is moving more into these states that are ventral, of grounding. And we call them, I made this graphic model, which we use. I just called it the 6 F's to make it simple. So the grounded place we call flock, because this is where we come together. And in that place, you know, what is it that's going to help you to be able to feel more comfortable and centered in your body, so that you don't have to hurt your body anymore as an attempt to help it? And however that comes, that really my focus is on the body, on the nervous system. And then when you do that, you move it away from trying to control the addictive behavior. It comes with it. But we, of course, address it, but we address it in a very different way. It's like, how are we doing? You know, how's it going this week? And if the person comes in, they're like, whoa, you know, and I wouldn't start with that either. But I'm like, okay, so something's really scaring your body.
Yeah.
Something's scaring your body and you don't feel safe. And so let's work with that.
In what way is, you know, if I've kind of learned certain habits to jolt my nervous system or to get me in a certain state within my nervous system.
Yeah.
How important is it for me to learn other ways to regulate?
Huge.
And is that like sort of do skills come into play?
Yes, absolutely.
Strategies?
There is a real kind of pragmatic practices that we encourage every day for people to do, to develop these practices as a way of being able to then have options to choose. Okay, I'm going to do this instead of doing this. And when we work on the 2-hour workshop, I'll show you specifically how we do that. I use this thing called the 3-circle practice, which comes from Patrick Caron's work with sex addiction. Very pragmatic, very behavioral, because when you make up your mind that you do want to change these behaviors, of course, it's really hard. Because especially with, addictions that are really physiological, it's very, very hard to do, right?
Mm-hmm.
So we want to really encourage people to develop a life worth living. Behaviors and experiences that feel good, that are socially engaging, which often people don't want to do because we like to often do addictive behaviors alone, or in groups that are just all focused on that behavior.
Right.
So it's hard, but I work in groups all the time with folks, and we do focusing practice in groups.
Huh.
Yeah.
So you can apply some of these same principles, both in a group modality as well as an individual modality. Is there any advantage to the group modality, or for some individuals that's really a preferred modality as opposed to individual?
Well, when we think about polyvagal theory, we think about co-regulating and how people connect with that ventral place. And we are born in relationships. That's how we're designed to relate to each other. This is how we thrive. And so, yeah, I mean, I think that's one of the things that about the 12-step program that has been so successful is the group work with socially engaging together, co-regulating with each other through the body, through breath. As Steve would say, breath is one of the major portals to the ventral vagus, the grounded part of the body above the diaphragm, right up into the face, right? This ventral branch. So when you focus together in group, these groups are extremely powerful because we're listening not to just what you're saying up here, but we're listening to how what you're feeling is connected to what's happening in your body. And then you get these shifts, these felt shifts in the body that brings a release, but it's not the jolt from kicking the cat. It's a release into feeling connected and heard and appreciated. And even when it's painful, the release comes. And that's what I put together in the model, that what occurred to me was that these felt shifts in the body that come with this deep listening are shifts in the neurophysiological nervous system. Does that make sense?
Yeah. Well, what you're really saying is, I mean, the really bottom line to so much of what you're sharing with us is to try to reconnect the mind to the body here. Right?
Yes.
Because we can sometimes feel like we're in that realm of let's look at behavior, let's look at thought processes, but that mediating variable or intermediary variable is there is that you are in a body. Human beings do have bodies, right?
Yeah, they're worth more than just carrying around the brain.
Yeah, they're not just carrying around the brain, right? And it's this area which has, you're saying we're beginning to increasingly see and a greater appreciation for the role of bodily sensations, imagery, all those aspects that are interconnected with our belief systems, with our behavior,
with making meaning in the world,
meaning in life. Right?
Yes. And this is, of course, is what shattered with trauma and addiction. Is it shatters the sense of meaning? Like, what's the point? That again, lots of us are experiencing now in the world. But bodies carry meaning. Bodies know a lot.
Well, what you also are bringing our attention to that. This isn't just where individuals are experiencing this kind of dysregulation. We now have entire societies and communities.
We now have the whole world now.
And now we have the whole planet.
Because of Ukraine, that the whole world is in. I was thinking before we met today that that polyvagal theory is really like a trauma-informed understanding of the nervous system. Yeah. Because Steve brought in that dissociated place of the dorsal vagus and also the social engagement system. What gets us out of that is connection. right? Like this interview, for example, I really enjoyed because I feel like we made a connection that feels good. But you can have other interviews that are like, ugh, because
Oh, let me tell you, I've had them, Jan.
me too, because there isn't that connection.
Right.
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 And so now I'll go off and I feel good. Like this was fun. We had a good time, even though we're talking about things that are tremendously painful.
Yeah. Yeah.
And that's healing.
Yeah. Well, I think part of it is hopefully there's a sense of mutual respect.
Yes.
There's also a lot of listening.
Yeah.
There's a respect for that other the person's perspective, that the questions are really designed to enhance understanding rather than to get you.
Rather than evaluating. So what we're saying, Tony, is that there's a measure of safety that we've established together. Yes. And when we reference the body, then it really feels substantial, right?
Right.
It's nourishing. Whereas if we didn't reference the body and you didn't create enough safety by maybe you were evaluating me, like firing questions, well, what about this? And what about, then it would be a totally different experience.
Yeah. And, there are times that we may have some disagreements, but there's a difference between like productive, respectful disagreements and the kind of thing where we become warring tribes, right?
Yeah, because that's crucial. And what you're raising again, another very important part of polyvagal theory is about establishing safety so that we can really connect and we can be curious with each other. And then we can be compassionate with each other and we can delight in what we don't agree with. Go, wow, tell me more about that.
Right.
You see it like that, and to be open about changing.
Well, I think that's really maybe the most critical piece. And one takeaway anyway, is that my very first job and when I'm working with someone is to understand their experience and their perspective in the absence of judgment, in the absence of anything that can promote shame and guilt. That's critical in terms of creating that kind of like safe space. Well, I've been feeling in a very safe, but I've been in another state though. It's more than just safe. It's kind of like an excited state. Yeah. I'm not sure which part of the nervous system that's all about.
That is ventral sympathetic. It's a blended state, and I have it in my model, and I call it fired up.
Yeah.
Because we're fired up because there's sympathetic energy in what we're doing, but we still feel grounded. Safe enough with each other. It's different than just flying up into flight fight.
Oh, no. It's not none of that at all. It's this idea of, gee, I'm learning something new. My mind is being stretched. It's very part of curiosity. Yeah. That, gee, I don't know who Jan was before this conversation. So I got to know someone who presents some insights and experiences. So it's both kind of like fired up, but feeling in a very, very comfortable place and thinking more about, gee, how can we build on this to support the system that we have out there?
Exactly.
And to support the workforce that has been going under tremendous degrees of stress. Yeah. And I know that now I'm feeling a little unsafe because Kara's going to say, Dr. Salerno, you're going over time again.
There's all these questions.
You see that? Now I'm back into my sympathetic nervous system. And I'm going to have to go get a drink or something. All right, Kara.
Hi, thank you so much. This is a wonderful conversation. And I love that Tony just kind of exemplified your work at the end and in a nutshell, right, around how you make people feel. And it does remind me of that quote of, we may not remember what someone said, but we remember how they made us feel. And we have a few questions, a bunch of comments, a bunch of beautiful comments, and a few questions I'd love to get your feedback on. So one question, I was having a conversation in the chat, a few of us were around, do women ever really feel safe? Can we in this paternalistic society? And then it made us think about anyone outside of dominant culture and can anyone really ever feel safe?
Yeah.
And I would think, yes, is surrounded by others who help them feel safe. But then other people are thinking, no, not so true. So wondering about kind of different populations and safety and around, addiction, as well as just feeling safe and how that impacts addiction and trauma experiences as well.
Yeah, no, that's a great question. And, really addictions come from the lack of safety, right? So the way that I think about this question, and I think about it a lot, goes right back to the very beginning of my work 40 years ago with one of my greatest teachers, Sandra Butler, who wrote one of the first books about incest called The Conspiracy of Silence. And when I was at a workshop that she gave in Toronto, somebody asked this very question: how can people ever feel safe? How could we ever tell our clients, don't worry, it'll never happen to you again? And she said something that I've never forgotten, many things, but she said, being able to establish some sense of safety is very important to me. And the way that we do that is through moment by moment. So right here, right now, you and I, Kara, can say, right in this moment together, can we feel some sense of safety together? And I do. If I take it to the next moment, I don't know, but that's true anyway of life. We never know what's going to happen, right? But in these moments, moment by moment, it's very important to invite some sense of connection with self and other so we can start to heal. Because we can't really heal without feeling some moments of safety. And we try to build that with our clients and in our lives with our relationships. But it really is moment by moment. And especially now for people that never had to worry about it. And that's the way lots of marginalized people live their whole lives.
Yeah.
Lots of our clients live their whole lives. So we have to be very careful when we talk about the concept of safety.
Mm-hmm.
What does that really mean for
Yeah.
people that, are food insecure, who are being, for women with misogyny, for racism, it's just, yeah.
And do you have explicit, you recommend these explicit conversations around safety?
Yeah, absolutely.
In a constant way. Mm-hmm.
Yeah.
Wonderful. Yeah, I wonder sometimes if we talk enough about safety in our work.
Well, yeah, and I mean, this is, Steve just wrote a book called Polyvagal Safety. His whole, he's just been talking about how his whole life's work is really about safety, which is what the autonomic nervous system is all about.
Yeah.
Neuroception, right? Am I safe? Am I not safe?
Yeah. Well, on that note, somebody said, can Jan please explain the three branches of the ANS? I am used to only understanding two, the sympathetic and the parasympathetic. Right. So the sympathetic is the flight fight one that we know about, and we've known about for a long time in the traditional model. In the parasympathetic, there are two branches of the parasympathetic. So the ventral branch, which is that calm place in the body, and then the branch that's dorsal. So the dorsal branch of the vagus is that state that we recognize as trauma therapists of dissociation that Steve named in the work that he did with neonatal infants, in noticing that those babies whose lives were threatened, they weren't going into the sympathetic flight fight. Their heart rates were lower. So what was that about? That was the dorsal vagus. Yeah. Thank you. Somebody asked, can you share your embodied assessment tool with the group? It would be much appreciated. Is that something that you'll go into in our training? I'll go into it in the training. Yeah. Okay. Yeah. Okay. So it just came out as a download on my website, and I am really excited about it. I'm doing consultation groups where we're using the assessment tool, but so I'll go into it in the training. So please join our part 2 on the 20th, and we'll be going over that. So somebody was so two interesting kind of comments and questions. Somebody was talking about in school, we learned that self-disclosure is taboo. but how actually it sounds like you're recommending that self-disclosure is a part of creating a safe space and creating
Yeah.
safety.
Yeah. And this is one of the things I also really love about polyvagal theory and Steve's work is that, you know, when we work in the body, the way that we work is different. For example, we pay attention to a client that comes who's hungry. We share something about ourselves, human being to human being. Absolutely. I think a lot of our boundaries have been formulated out of fear. And I was doing this work 40 years ago when that happened with the false memory syndrome. And we all became terrified. We're going to be sued if we ask if you were abused. But then what happened is we've developed these ways of being together that are based on fear. We don't touch our clients. We don't, but it's all like, so I'm supposed to behave in a way because people do things that hurt other people, but that doesn't really bring us into a socially engaged, warm human connection.
Mm-hmm.
So surely we can work on establishing boundaries around touch and self-disclosure that are, of course, bounded, and they're in service of the client relationship. That's really, I think, the key. Is it going to help this client if I share with them, I'm a human being too, just like you? Or are they going to feel overwhelmed? So timing is important too. Yeah, very much. Or, you know, you may go for a walk with your client, which of course was seen as being really bizarre when I started. But if the person is slipping into this folded in place of dorsal where they're immobilized, one of the best things you can do is invite a walk in the park. Get the body moving into the sympathetic nervous system more so that then they can be more present with you to actually show up to do the work.
Mm-hmm. Yeah, wonderful. So somebody said this is not the experience that many individuals receiving addiction treatment are currently receiving. Often treatment is designed to break down the barriers that individuals put up to keep themselves safe. How would you explain to treatment providers that this approach of breaking down an individual's barriers can be more harmful than helpful?
Well, you know, we just did a forum on that with the United States Association of Body Psychotherapies. I would explain it like this through this conversation that we've just been having, that there's another way to be able to be with and to treat addiction, which is very different than the traditional model. And this is the way. But it's hard. It's hard work. We're slowly beginning to make some inroads into addiction centers, but it takes time. You have to be patient.
Mm-hmm. Yeah.
Which I've learned a lot about over the last while.
I'm sure. Well, we're in a paradigm shift, and
yes.
Change is never easy even when it's good. It's usually not any.
Yeah. But when you appeal to people through the body, we're all human. We all live in bodies. And as soon as you start to address that in a way that's not threatening, people start to listen.
Yeah. Last question. Any suggestions on helping partners or family members begin to support or even understand some of this with a family member? So if there's a young person coming in who is, addicted to substances, how do we help family members understand?
So I created another application of the Felt Sense model that uses the dialogue from imago therapy, and it's working with families and children using polyvagal theory. And we'll get into that in the workshop as well, because it's very important, right, that you bring along family members into the healing process. So we have a way of doing that integrates Harville Hendricks and Helen LaKelly Hunt's work, Imago, IMAGO.
Yeah.
And you can also, again, if you go to my website, janwinhall.com, you can download the models. They're very colorful graphic models that we use.
Yes, wonderful. Yeah. Harvey and his wife's work is all about safe conversations, right?
Yes, exactly.
How do you have safe conversations? I love that work. I think it's
really great. Yeah, we'll get into it.
Okay, love this. Okay, just as a reminder, join us for part 2, Trauma and Addiction with Jan Winhall on Wednesday, April 20th from 10 a.m. to noon. If you registered for this event, you are registered for part 2. So I think you should be fine. You'll receive a reminder of the link and you'll join us for this awesome training. And then I just want to review a few upcoming events that we have. We have on March 23rd, internal family systems therapy, an overview and best practices. So if you've been curious about IFS, please join us. Monday, March 28th, using core psychosocial rehabilitation, PSR, to support education and employment goals. Wednesday, March 30th, building on the strengths of youth who have endured hardship, which is about resilience, Dr. Ken Ginsberg. And Wednesday, April 13th, grief and transition aged youth. Okay, so thank you so much for joining us. Dr. Salerno, do you have any last thoughts?
No, just to, thank you very much, Jan, for a very, not just sort of interesting, but I think inspiring presentation today and conversation. It has fired me up, and I think it's fired up a lot of other folks as well. But we don't burn up, we just get fired up. So thanks so much. We really appreciate it. And for all of you who took the time in your very busy schedules to attend this, we really appreciate that as well.
We sure do. And as Maddie Gold said, this training is so vital to understanding addiction. So glad I'm on this. It's so good. I agree, Maddie. And so thank you, everyone. We have a lot of people thanking you, Jan, and thanking you, Dr. Salerno, for this amazing conversation. And Jan, any last thoughts from you?
I'm really excited to share this work. Really, it's a privilege to be able to do this. I really mean that. So thank you for coming. And I look forward to April 20th. We'll do more.
Yes. Awesome.